I'm Dr. Andrew Block. I'm a clinical psychologist, and I received my undergraduate training at Haverford College in Haverford, Pennsylvania, majored in psychology. Then went on to Dartmouth College and got a PhD in psychology, where I did my dissertation on chronic pain and its effect on the family. In 1990, I joined the Texas Back Institute as the director of behavioral medicine and have been there ever since. I began working with a physiatrist back in 1984, and at that time we were working initially in a chronic pain program, a multidisciplinary chronic pain program. But that physiatrist and then a number of the physicians that referred to him asked me to perform pre-surgical psychological screenings. The assessment of psychosocial issues is important prior to implant therapy for a number of reasons. First, the patient's emotional state and personality factors can influence how much relief and how good of a response they get to the device. We've found that patients who have high levels of emotional distress or who have unstable psychosocial situations tend to not get as good pain relief and to not reduce their pain medications or return to work at nearly the same rate as patients who are doing better emotionally and interpersonally. In addition, what we are able to do through the assessment of psychosocial problems prior to the stimulator or device is to discover other techniques that might augment the effectiveness of the stimulator. For example, if the patient's depressed, we might recommend antidepressant medication. Or if they tend to perceive themselves as victims, we may do a little psychotherapy to help them get more involved in their treatment and more active in their rehabilitation. We also can discover through the psychosocial assessment alternatives for patients where the stimulator might not be effective or where their expectations for the stimulator are unrealistic. The process of actually determining the prognosis of the device is a numerical or statistical one. Each one of the things that we give to the patient, the semi-structured interview, each questionnaire, can generate a numerical score, or at least a checklist, a yes-no kind of checklist. We then have an algorithm that is frequently used where all the interview data and the test data and data from the review of medical records are combined to generate a psychosocial risk score, and that score translates into what our prognosis is for the patient. A pre-surgical psychological screening report should really involve 4 components. The first is a specific determination of psychosocial outcome prognosis. In other words, how do we expect the patient to respond to the device based on our evaluation of the medical records, the interview, and the testing. We give a 5-category outcome prognosis in our facility: good, fair to good, fair, fair to poor, and poor outcome prognosis. The next step in the report is to include a listing of the patient's psychosocial risk factors in a bullet form so that the physiatrist can see, without having to go through the entire report, things like depression, substance abuse, history of pre-existing psychiatric disorder. All those are major psychosocial risk factors, and that will allow the physiatrist to use that information without having to delve into the wordier sections of the report. The third step involved in the report that the psychologist gives to the physiatrist are the specific actionable outcome and intervention suggestions. These are things that may be steps that the physiatrist can take to either augment the outcome of the surgery or to stand as alternatives. Things like getting the patient on an antidepressant medication or requiring the patient to reduce their narcotic medication prior to the device implant. That latter suggestion can help to test the patient's motivation and compliance. Sometimes we'll require the patient to stop smoking, another compliance measure. Finally, if the patient has a psychological or psychiatric diagnosis, that should also be included in the conclusion section of the report. Not all patients have that kind of diagnosis. Many patients that we see simply are having a life circumstance problem and don't really fit the criteria for a psychological or psychiatric diagnosis. But if there is one, that should be noted there. Once the pre-surgical psychological screening report is generated, then we immediately fax the report to the physiatrist, along with, of course, the outcome, prognosis, and treatment recommendations. Normally, we know the physicians are busy, and if the outcome prognosis is one that would say that it's okay to go ahead with the implant, then we don't call the physiatrist or really have any verbal contact with them. However, in the case where the patient has a high level of psychosocial risk, or their expectations are out of line with what might be appropriate for the stimulator, then it's very important to the psychologist and the physiatrist to have some interaction, to get together, so that for one, it can be decided who's going to tell the patient what the psychologist has determined. Many times it's very disappointing to the patient if they have a high level of psychosocial risk and they've got their heart dead set on a stimulator. That can be upsetting and disappointing. A lot of times it's better to have the psychologist at least give some indication of that to the patient. But again, it is the physiatrist who makes the final call, and we consider the pre-surgical psychological screening like any other diagnostic test, like a myelogram or an EMG or a discogram. And the physician has to take all those different types of tests together and make a determination of treatment course. The pre-surgical psychological screening is that kind of tool. The team approach involving a physiatrist and a psychologist and usually other members of the medical treatment team is really critical to the successful treatment of patients with chronic pain. This is what we call a biopsychosocial disorder. It has both physical, psychological, and social parameters. And in order for the patient to really progress completely, they need to progress on all these fronts. As the patient begins to feel physical improvement, then their mental state improves. As they overcome their dependence on medications, they're able to do more, which allows them to function better. All these pieces fit together, and the treatment that's most successful and effective involves not only the patient being able to experience all those gains, but the staff being able to talk about what the patient's doing, what's being effective, what's not being effective, so you can make adjustments and individualize the treatment approach to the patient to take into account all the problems the patient is experiencing, so you can use treatments in one area and gains in one area to make gains in another area. Physiatrists can benefit a great deal by the inclusion of psychologists and psychological services within their treatment approach. Of course, the psychologist is just a member of the treatment team, and we don't consider ourselves to be the primary member. We're ancillary members. It's the physiatrist who basically sets up the treatment plan and calls the shots. We can assist in the assessment and in the treatment, but our input may only be a small part of what the physiatrist is taking into account, and sometimes we are unaware of all the different diagnostic testing or concerns, so the physiatrist needs to also make certain that the treatment is not completely psychological when they're treating a patient who has physical pain. One thing I would advise physiatrists not to do is to tell the patient that if they fail the pre-surgical psychological screening, they will not get the device. A lot of patients tell me that that's what they've been told, and then they come in and they also tell me at the same time that they really can't reveal anything because they want to get the device so much that they're afraid of saying the wrong thing. So remember that this is not a make or break evaluation. The psychologist is an ancillary healthcare provider. We provide a diagnostic test just like a myelogram, CAT scan, EMG. A psychologist can be a key member of your treatment team, adding a lot of insight into what's wrong with the patient and how to best treat the patient. Most physicians are not trained to identify psychological problems associated with pain. And a well-trained psychologist will be able to identify those things and be able to provide specific steps that you can take to make your treatments be more effective. It takes an element of trust, that you trust the psychologist's judgment and recommendations, and it also takes building a relationship so that the psychologist understands the way the physician thinks. One of the things that I've learned over the years is that of the many physicians that refer patients to me, each one has a different approach to patient management. Some of them will require patients to take no Schedule II narcotics. They won't ever give them. Others will not be shy about giving those medications at all. Some of them will require more intensive rehabilitation. Some of them won't require that at all. A psychologist needs to be able to adjust their treatment recommendations to the specific physician they've got while holding true to the general algorithm that they use for determining psychosocial risk. But in all those ways, a psychologist can really add a lot of richness and a lot of treatment suggestions and appropriateness for the intervention that the physiatrist provides.